All right. Hi, everyone. I'm going to give everybody a minute to come in and get everything set in place. Okay, give y'all a couple more minutes. All right, let's see. Got a few more people coming in. Okay, so I'm going to go ahead and get started. We are right at 12 o'clock on the dot pretty much. So hi, everyone. My name is Ellen Dunn. I am the program coordinator and social worker with Alzheimer's Services. Thank you all again for joining us for another Lunch and Learn session. This is actually going to be our last Lunch and Learn for the year. We have our November awareness coming up next month. And so I kind of want to talk about that before we get kicked off with the Lunch and Learn. So the month of November is Alzheimer's Disease Awareness Month. And so every year we try and plan a number of fun activities and fun things for people to participate in to sort of honor caregivers, but also spread education and awareness in the community about Alzheimer's disease. So this year, since we're in our new virtual world, we have a few fun things planned. I just want to touch on them real quick, but you'll get emails about them. You'll hear about them on our Facebook and everything like that. So the first will be similar to Lunch and Learn, but we'll have 3 financial literacy sessions in November. And so keep an eye out for those topics and those dates. And those are going to be topics related to different issues that maybe caregivers face related to finances and the burden that finances can, cause for in the caregiving situation, and answer some of like the questions that a lot of people will have. We're also going to have a Q&A session where we're going to have local professionals come on, and it'll be through Zoom, and caregivers will have the opportunity to submit your questions ahead of time and then have them answered by those professionals. We're going to offer online memory screenings. Usually every year we go out into the community and offer those screenings, but this year we'll be doing them through Zoom. And then last, we'll have our fall festival, which will be a socially distanced music festival that we're going to be holding. Registration is very, very limited for that. So just keep an eye out for those emails on all of those different types of events. And hopefully you can join us next month. So next thing is just a couple other housekeeping announcements. I will be recording this presentation. So if anybody would like to watch it or has a loved one they want to send it to, it will be up on our YouTube channel, hopefully by the end of this week. And if you have any questions for Rachel anytime during the presentation, go ahead and put those in the chat box and we'll go through some of those questions at the very end. But I just want to introduce Rachel Castellanos. She is with the Association of Frontotemporal Degeneration. She's here local with us in Baton Rouge, and she is a caregiver for her mom. So I'm going to let Rachel have the rest of the time, and thank you so much for being here with us, Rachel. We're so excited to hear all the information you have.
Thanks, Ellen. Good morning, everyone. My name is Rachel Castellanos, and I'm a local AFTD volunteer living here in Baton Rouge. AFTD is a national nonprofit organization that envisions a world with compassionate care, effective support, and a future free of FTD. Okay, just give me a second and I'll pull the slides up for you all. Okay, can you see the slides, Ellen? Yes, everyone? Okay.
Yeah, looks good, Rachel.
All right. As Ellen mentioned, my mother, Mary, who lives in Metairie, was diagnosed with frontotemporal degeneration, which is also sometimes called frontotemporal dementia, or simply FTD, in 2013 at age 60. And she is still struggling with the disease today. We identified unusual changes in her behavior and changes in the way that she interacted and communicated several years before her diagnosis. But as is the case with many other families, it took a few years to get an accurate diagnosis. She has suffered from both cognitive, language, and behavioral symptoms attributed to FTD, and now later in the progression of her disease, she also suffers from motor-related symptoms like inability to walk and bear weight and use one of her arms. My father has been a tireless and dedicated caregiver and has done everything humanly possible to keep my mom at home with him. But to say that it has been challenging is an understatement. I started volunteering with the Association for Frontotemporal Degeneration, also just known as AFTD, in 2014. I was frustrated there was nothing I could do to make my mom better, and I wanted to channel that frustration into an opportunity to take action. Volunteering for AFTD has been a wonderful experience for me, and I have met and connected with many other families impacted by FTD over the years. I have learned valuable lessons from others who have walked in similar shoes with respect to FTD, and I am privileged to speak to you all today, other caregivers, family members, and professionals who are impacted by FTD. This is just a little personal slide. It's a picture of my family with my mom a few years ago at the last beach trip that we were able to take with her. And next to the photo is our excerpts from a poem that my sister wrote in honor of my mom and her struggle with FTD. All right. AFTD and the Alzheimer's services of the capital area have asked me to talk to you all today about the FTD disorders and the specialized treatment and care approaches for FTD and the resources and support AFTD can provide persons diagnosed, their families, caregivers, and healthcare professionals. What is dementia? Before we talk about FTD, we need to first define dementia because FTD, although it is a rare disease, is also a form of dementia. Dementia is a global term that reflects changes in thinking, behavior, and emotions. The Alzheimer's Foundation of America defines dementia as a group of symptoms such as loss of memory, judgment, language, complex motor skills, and loss of other intellectual function caused by the permanent damage or death of the brain's nerve cells or neurons. Many medical conditions can cause dementia, and some types are reversible, but unfortunately, neurodegenerative diseases like FTD do progress over time and are terminal. They eventually lead to complications that cause death. FTD is the result of a degeneration of neurons or nerve cells in parts of the brain called the frontal and temporal lobes. As neurons die in these areas of the brain, the areas of the brain begin to harden and shrink. This will gradually cause difficulties in thinking and changes in behavior that are normally controlled by these parts of the brain. FTD is primarily a behavior, language, or motor disorder. Memory is not the primary symptom, and in fact, memory is usually preserved. FTD is marked by a gradual and progressive change and decline in behavior, language, and motor functioning. Onset of FTD symptoms ranges from the age of 21 to 80 years old. However, the majority of the cases occur in individuals between 45 and 64 years old. The average age diagnosis is 57, and the younger age of onset means that people are physically active, they have fewer comorbid health issues, and they are deeply engaged in work, family, and social lives. Data suggests that there are about 50 to 60,000 people in the US with FTD, although many believe the number is much higher. This is due to the fact that FTD is difficult to diagnose and is often misdiagnosed as a different medical condition. But because the prevalence is below 250,000 people, FTD is considered a rare disease. Many in the medical community, unfortunately, remain unfamiliar with it. It is frequently misdiagnosed as Alzheimer's, depression, Parkinson's disease, or a psychiatric condition. On average, it takes about 3 to 3.5 years to get an accurate FTD diagnosis. FTD is terminal, and the average life expectancy is 7 to 13 years after diagnosis, but it does vary greatly from person to person. A Approximately 40% of individuals with FTD do have a family history that includes at least one other relative who also has or has had a neurodegenerative disease. Over 50% of the other cases of FTD are considered sporadic with no familial component or connection. FTD really creates the perfect storm. It's rare, it's poorly understood, and it has a younger age of onset in the prime of someone's life. This equals higher stress, higher isolation, and a higher caregiver burden. In 2017, the scientific journal Neurology published both electronically and in print a study that was funded and co-authored by AFTD called The Social and Economic Burden of Frontotemporal Degeneration. The study showed that the average annual costs associated with FTD are roughly double those that are associated with Alzheimer's disease. Alzheimer's disease costs are around $64,000 per year, but the costs associated with FTD are about $120,000 per year. Much of the difference can be attributed to the loss of productivity and income due to the younger age of onset in FTD patients. The study showed that household income falls by as much as 50%. 12 months prior to the diagnosis, the average overall income ranged from $75,000 to $99,000. And 12 months after diagnosis, that income declined to the $50,000 to $59,000 range. The study also showed that nearly 40% of caregivers surveyed said that they were no longer employed following the patient's diagnosis. And for those caregivers who were employed, they reported losing 7 work days in the most recent 4 weeks. There may be children still at home, teens or young adults, and the caregiver may be already caring for an aging parent. So an FTD diagnosis can create complex financial needs, significant role changes within a family, and the fact that many with FTD are physically active and young adds to the care challenges. The study highlights what many of you probably already know, that FTD not only significantly changes and alters and impacts the life of the person diagnosed, but it also significantly changes the life of family members and caregivers. On top of the perfect storm, FTD is also difficult to diagnose. We hear a lot from families that diagnosis is a very frustrating process of families pushing doctors to see the changes that mimic dozens of other medically explained conditions. It takes about 3.5 years on average to get an FTD diagnosis versus 2.6 years to get an accurate Alzheimer's diagnosis. The symptoms are often misinterpreted or misdiagnosed as depression, bipolar disorder, stroke, anxiety, or relationship and marital issues. Most physicians have not had specific training in FTD or are not suspecting dementia in a patient so young. The first several years can be very frustrating and confusing. We do not currently have any biomarkers or ways to give 100% certainty of diagnosis until autopsy of the brain, or in familial cases via genetic testing. Therefore, doctors must use several methods to make a clinical diagnosis, and it is recommended that the evaluation be completed by an FTD specialist. Or if there's not an FTD specialist in the area, it's important to find a physician who at least has experience in diagnosing and treating an FTD patient. Family input is critical. The person diagnosed may not be aware of their symptoms or changes, and doctors need context from family members to appreciate and understand the change. AFTD recommends keeping a log of symptoms and documenting those changes in writing so that the family can bring those to the physicians when discussing changes in their loved one. FTD is the most common cause of dementia under age 60. It affects behavior, language, and motor functions, but memory is not usually affected. The younger age of onset, the poorly recognized symptoms, and the rare occurrence all add to the profound impact of FTD. As you can see, FTD is not just one disease, it is very complex. Clinical diagnosis is based on the doctor's exam, patient history, and symptoms. It is important to highlight that clinical diagnosis is based on what the doctor can physically see, backed up by blood work, imaging, and other diagnostic tools. Diagnosis involves a medical history and detailed neurological exam, a neuropsychological exam to assess language, behavior, memory, executive and visual spatial functions, neuroimaging tests to determine where and how extensively the brain regions have atrophied or have lost blood flow. Some of these neuroimaging studies can be an MRI scan, a SPECT scan, or a PET scan. As you can see on this slide, FTD can be grouped into three main clinical presentations. First is the progressive behavior and personality decline. The second is progressive language decline. And the third is progressive movement decline. Another contributing factor to the difficulty in diagnosing FTD is that more than one FTD disorder can be present at a time. Many affected individuals have overlapping symptoms, particularly as the disease progresses. But usually each disorder can be identified according to the symptoms that appear first and most prominently. To give this context, my mother was initially diagnosed with primary progressive aphasia, the progressive language decline disorder. But a year or two after her diagnosis, she also began exhibiting severe changes to her behavior and personality. And now, as I mentioned earlier, late in the progression of her disease, she also has deficits in her motor functioning capabilities. The regions of the brain involved in FTD and the cognitive skills they control can be seen on this slide. Location of the disease and where the disease starts determines what symptoms occur, especially when we're talking about the earliest symptoms. The presence of disease in particular brain regions, the neural circuits, and the networks determines what symptoms will manifest. Starting with the cognitive symptoms of FTD, persons diagnosed with FTD may have difficulty completing usual tasks of daily living at home and at work. They may have difficulty with attention, which can look like apathy, and they may have difficulty with reasoning and problem solving and difficulty adapting to change. To give a few examples of things that we experienced with my mom early in her disease, she began having difficulty operating the telephone and making phone calls. One big flag before she was diagnosed is she was unable to disarm and operate the security alarm in our house that had been the same code for 15 years. She just was no longer able to enter the code and disarm it. And another thing that happened very early on in her diagnosis was while she was still driving, she was able to drive to places that she was very familiar with, but anytime she had to go someplace new, even if it was in a familiar neighborhood, she wasn't able to follow directions or take directions. I remember distinctively moving into a new apartment years ago, and it was in a neighborhood she was very familiar with, but when I gave her directions, very detailed, specific directions, she was not able to find her way. I tried to direct her over the phone how to get to my apartment. She was not able to get there. So I had to tell her to park, stay put, and I had to get in my car and go find her. This slide goes over some of the behavioral symptoms in FTD. There may be a loss of empathy, showing no emotions or seeming flat or disinterested. A person with FTD may act impulsively without considering the social effects of the inappropriate behavior. They may have lack of insight that the behavior can offend others or cause harm. They may exhibit repetitive behaviors such as repeating catchphrases, counting out loud, humming, lip smacking, hand rubbing, or clapping. They may exhibit excessive eating and weight gain. They may have rituals or repetitive routines. They may touch or use items in their view when not socially appropriate. An example of this that sticks out in my mind is many years ago, I was leaving a restaurant with my mom during a rainstorm, and I had an umbrella in my hand and I was about to open it so that we could walk to the car, but she just impulsively grabbed an umbrella out of the person's hand that was standing near us. Obviously, that was impulsive, unexpected action. It took the other person by surprise, but it's a good example of how someone with FTD just reacts without the executive functioning or reasoning. They may exhibit delusions or other abnormal or unusual thoughts. This is also something we experienced with my mom. One day she just started exclaiming, "Don't do that to me. I know what you're doing." It was totally out of the blue. We weren't expecting it. We had no idea what she was talking about, but it can happen. We've talked about the cognitive symptoms and behavioral symptoms, and now we'll move on to the language symptoms associated with FTD. The FTD disorder of progressive language decline is called primary progressive aphasia, or abbreviated as PPA. The first 2 years of PPA is characterized by a progressive change in language function. Other cognitive functions are relatively preserved, and there can be problems with language expression, language comprehension, and word retrieval. I want to move back a few slides to the FTD disorder characterized by progressive movement decline. We have corticobasal syndrome, progressive supranuclear palsy, ALS with FTD, and FTD with Parkinsonism. And these are all characterized by changes and decline in motor functioning. More than other forms of dementia, FTD attacks the social brain, which relies on circuits in the frontal and temporal lobes. As we covered earlier, we know this creates changes in personality and executive functioning, which make it difficult for loved ones as well as professional and family caregivers to cope with the changes. There is often a sense from loved ones that the person diagnosed is blaming the family member or purposefully trying to hurt family and friends with their actions. But it is important for family members to realize that this is not the case, and that the person diagnosed with FTD is not intentionally acting inappropriately or intentionally failing to show emotion. Understandably, however, this is a very difficult and painful process for a lot of caregivers who take the symptoms of FTD personally. This can create a rift in relationships and a high level of psychosocial needs for the families as they continue to care for their loved one with FTD. It is also difficult and challenging for professional caregivers. We can't stress enough the importance for both family and professional caregivers to remember that the person diagnosed with FTD is not intentionally trying to be difficult or challenging. On the other hand, I also can't stress enough the importance of caregivers asking for help. Caregiver burnout is terrible and it happens, and it's really important for a caregiver to get help and assistance when they need it. There is great diversity in FTD. There are unique backgrounds, symptoms, and experiences within the disease. Managing FTD symptoms is a challenge and is highly individualized for each patient. There are no disease-specific treatments, but there is a growing body of experience and strategies that can minimize symptoms and address quality of life for the person and caregiver. A person with FTD and their family members are served best by developing a collaborative working relationship between a primary care physician and specialists like cognitive behavioral neurologists, psychiatrists, or neuropsychologists. Although there are no medications that have been proven effective specifically for FTD, many clinicians look to the medications and treatment approaches used in other similar disorders to develop a therapeutic approach. Some medications, however, can make things worse rather than making them better. So it goes again to the point of how important it is to work with a medical professional and doctors that are familiar with FTD. Research, however, is advancing, and we are seeing some initial clinical trials take place. At this point, however, there is no magic cure and no medicine that can make it better. But behavioral approaches are by far the key to managing inappropriate behaviors. Careful observation of behavior, along with interventions that the person has responded to in the past, may provide clues for additional behavioral interventions that can be helpful. AFTD has information and newsletters available on its website that specifically address the behavior and care challenges presented by FTD. And I encourage you to use these resources when developing your approaches to care. Drawing on my personal experience, we were very lucky to find a neurologist eventually that had familiarity with FTD and had treated FTD patients in the past. He referred us to neuropsychologists for testing. And when my mom's behavioral symptoms and aggression and delusion started, he worked with a psychiatrist to develop a medication plan for management of those symptoms. He also referred us to a speech therapist early on in her diagnosis to help with her communication and speech deficits. But I will reiterate again the importance of finding a professional with experience or at least knowledge of FTD, because the speech language therapy that my mom received really was not effective at all. I don't think the speech language pathologist had experience in working with dementia patients, and it really showed in her interactions with my mom. On the flip side, a few years ago, we found a music therapist for my mom who has been a blessing and has extensive experience working with dementia patients and has just been really effective and soothing for my mom. As I just mentioned, speech language therapy can help the person diagnosed and the caregiver develop compensatory strategies for the loss of communication and language. Patience and simplicity in communications are important. It's important also to not interpret the lack of communication by the individual with FTD or their failure to understand or respond as resistance. And be an observer. This will allow you to identify the patterns of behavior and the symptoms along the way. And it will also allow you to adapt to changes in the symptoms as they happen. Compassionate communication is key. Avoid reasoning, arguing, or criticizing the individual with FTD. Elevate your level of respect, generosity, and graciousness. Recognize and remind yourself that your approach will need to change over time as the disease progresses. And remember, it is not the person, it is the disease. The individual with FTD is doing and saying things that are normal for a person with dementia. And you as a family member or caregiver cannot control the disease, but you can control your reaction to it. Communication strategy that I had to use with my mom early on in her diagnosis, when she was able to still communicate some and receive communication, was I had to really simplify the communications into one steps for her. So if I wanted to tell her to put the milk back in the refrigerator. Although that seems like a very simple statement, it was still too many steps and too complex for her. So what I would have to do is say, Mom, pick up the milk. Refrigerator. Mom, open the refrigerator. Mom, put the milk into the refrigerator. Obviously, this takes incredible patience and totally reworking the way that you are accustomed to communicating, but it is essential to be flexible and to adapt to each FTD patient's individual abilities when it comes to communication. Another thing that I found very effective in moments that my mom was struggling with her communication or having a moment of frustration was just the simple nature of touch and silence. Just holding her hand or rubbing her back and not saying anything and just letting her know that I was there for her was really effective. I mean, if you think about it, someone who's having difficulties with communication and language, sometimes using no words or little words can be really soothing and effective. AFTD is a nonprofit organization whose mission is to improve the quality of life of people affected by FTD and to drive research to a cure. AFTD works every day to promote and fund research, increase public awareness, provide information and support, educate healthcare professionals, and advocate. Everything that AFTD staff, board members, and volunteers do revolve around these 5 mission areas. AFTD's office is based in the suburbs of Philadelphia, but AFTD's volunteers, board members, awareness and education events, fundraisers, and support groups are located nationwide. AFTD's helpline is accessible to everyone from persons diagnosed, caregivers, friends, and professionals. The helpline is designed to answer questions, provide support and resources. You can call or email anytime, and a staff member from AFTD will get back to you. AFTD offers a few different newsletters. You can register for these newsletters on AFTD's website. There are also several publications available on the website, along with other valuable information for persons diagnosed, caregivers, and professionals. If you haven't already, I really encourage you to visit the website and look at these resources and educational materials. The AFTD website was the single best source of information for me early on in my mom's diagnosis. I was able to learn a lot about the disease and prepare myself ahead of time for what was to come. And it also gave me valuable information and questions I could bring to her neurologist when discussing the specifics of her symptoms and disease progression. In addition to the information AFTD provides on its website and publications, AFTD also offers an array of support resources. AFTD connecting with others who understand the disease can be very valuable. Many individuals with a diagnosis and their families can benefit from mutual support and are interested in sharing information, resources, and what they've learned from their experiences. AFTD has an affiliated support group network, and it oversees telephone support groups as well. In addition to the caregiver groups, AFTD offers 2 groups for persons diagnosed with FTD. AFTD also has a closed Facebook group for the FTD community, as well as a closed young adult Facebook group for people in their 20s and 30s whose lives have been impacted by FTD. AFTD offers 3 grants. The first is a respite grant of $500 a year for caregivers who have a loved one living at home with FTD. The second is a travel grant for caregivers to attend FTD conferences. And the third is a wonderful quality of life grant that is intended to help people diagnosed have access to services or support that will improve their quality of life. Sometimes AFTD can match FTD caregivers within a reasonable distance when they are not able to attend a support group in person. This is something we call a caregiver connection. You would just need to call or email the FTD helpline to ask for this. AFTD also hosts an annual conference in the spring for caregivers, persons diagnosed with FTD, and professionals. The conference is held in a different part of the country each year, and we're well into the planning phases for the spring 2021 conference that will be virtual next year due to COVID. Videos, if you're interested, of this past year's conference of spring of 2020 are available on the AFTD website. Another central focus of AFTD's mission is to educate physicians, nurses, facility care staff, and other professionals across all areas of healthcare about FTD and how to improve patient care. Partners in FTD Care is an education initiative of AFTD that brings together health professionals, experts, and families to promote understanding of FTD and to develop best practices in community care. It is a quarterly newsletter that is geared towards professionals, and each newsletter focuses on a particular issue or symptom related to FTD and includes relevant approaches to care. You can register to receive the Partners in FTD Care newsletter on the website. And I think this newsletter is also can be beneficial to caretakers because it does focus on managing symptoms. For any healthcare professionals that are interested in obtaining additional information, there is other resources on the AFTD website. Another aspect of AFTD's mission is research and promoting research. The FTD Disorders Registry is a secure electronic database that collects information from people diagnosed with any of the FTD disorders and from their caregivers and family members. Input from the registry participants will lead to better understanding of the impact of the disease on individuals and families. It will also fuel future research, including studies by scientists to learn more about the natural history of FTD. For what is still a far too little known disease like FTD, it is critically important to have a single repository that collects information from as many people as possible. The FTD Disorders Registry is fundamental to growing the FTD community, and it speaks to the value of research. As a volunteer, you can get involved in this area of AFTD's mission by sharing information and encouraging participation in the registry. You can direct people to AFTD's website and helpline to learn more about both the research and the registry. That's about all I have in terms of the presentation. Did we have any questions, Ellen, or anything that you want me to elaborate on? Or
we do. We have a couple of questions in the chat box, Rachel, and it's not too late to submit your questions. If anybody has them, you can type them in the chat box now. But the first one we have, Rachel, is can you share the name of the music therapist that you use for your mom?
Yes, her name is Jennifer. I don't remember her last name off the top of my head. Let me see if I have it in my phone. I might.
And if not, Rachel, you can always send it to me and I can email it out to everybody after.
Yes, let me just look real quick. I might have it here.
Sure.
Jennifer Bobeck, B-O-B-E-C-K. And she lives in the Mandeville, Covington area. I know she does travel to New Orleans. I don't know whether or not she travels to Baton Rouge, but she's amazing, and she may be able to provide a name of someone local to Baton Rouge. I don't know.
Okay, thank you. We have a few more questions. This one says, I do not feel that my loved one's doctor is completely in tune with the disease. Where and how do I find a doctor who has treated FTD patients?
Mm-hmm. Well, unfortunately, in Louisiana, we don't have an FTD center that a lot of other states have. So that is a disadvantage that we face here. I think you have to ask the physician that you go to if they have experience. I think that's the first step. And if not, do they know anyone who has experience in treating FTD patients? You can always call AFTD's helpline and ask for resources or support or advice from AFTD. They're always open to questions. And other than that, I don't really have any specific recommendations, but I think it's just a matter of interviewing your healthcare professionals. And if they don't have experience, and if you don't feel that they understand what you and your loved one are going through, trying to find someone else. I think connecting with other people in the online and telephone or in-person, support groups also is helpful. If you know other people who are going through what you're going through, you can share information and ask who their loved one sees for treatment. I think those are the best recommendations that I can come up with.
Okay, thank you. Couple more. This one says, how can you tell the difference between Alzheimer's and FTD? I'm guessing an MRI would show this. Is there any other way?
An MRI is one of the scans that can be ordered. Unfortunately, a definitive diagnosis cannot be given until after death upon brain autopsy. I think the younger age of onset, the fact that memory is preserved more often in FTD patients are some clues. But it's just keeping a log of the symptoms, and the symptoms really drive the diagnosis. The scans like the MRI, PET, and SPECT scan are also options that you can use.
Okay. This one says, can repeated head injuries cause FTD?
Well, I don't know about repeated head injuries with respect to FTD specifically, although I have read that head injuries can cause dementia generally. But with respect to FTD, I don't know that there's any data or research to show that it causes FTD dementia.
Okay. Is FTD misdiagnosed with early onset dementia?
FTD is a type of early onset dementia. I believe there's also an early onset Alzheimer's disease, and I would imagine that sometimes they can be misdiagnosed with one another. Was that the question, Ellen? Is it sometimes misdiagnosed as early onset?
Yes, I think it can be. Okay. Couple more questions, Rachel. I'm wondering if you could elaborate a little bit more on maybe some tips and some strategies for managing maybe challenging behaviors that this diagnosis can bring on.
Yeah. So it's highly individualized. Every patient has different symptoms, and every family has a different dynamic. It's, like I mentioned earlier, really important in developing a collaborative approach with your healthcare professionals, finding those healthcare professionals that are familiar with FTD. If there are severe behavioral issues, perhaps working with a psychiatrist for medication management, keeping a log of the symptoms so that you can bring them to the physician to talk about changes that have occurred over time and how you may be able to change the treatment approach and the management of symptoms. But unfortunately, there's no magic drug or cure. It's just about getting that good care team in place and having people that can follow your loved one throughout the journey. And again, excuse me, that Partners in FTD Care newsletter that I spoke about during the presentation really talks about each issue talks about a different behavioral symptom and how to manage it. And so I'd encourage you to go to the website and register for that newsletter.
Thank you. And the last question that we have right now, Rachel, can you just let us know if there's any data to support that an FTD diagnosis is more common in men or women, or?
There's no data to support that currently. It is a question that researchers are continuing to investigate. But right now, there's no data to suggest that it's more prevalent in one sex over the other, or one gender over the other.
Okay. Well, thank you so much, Rachel. And thank you to everyone who joined in and listened in on Rachel's presentation. It was so informative and so helpful, Rachel. So thank you so much. I'm going to send out a survey after this. If anybody has any additional questions or comments, I'll be happy to share them with Rachel. But thank you so much. And we look forward to seeing you guys again in the future. So everyone have a great day.
Thank you.